Hi, this is Arun Agrawal, and I am a pulmonary and critical care physician in the US. The opinions expressed here are only mine, and the institution I am affiliated with has no responsibility whatsoever to the presented content. This video is intended for physicians and respiratory therapists who work directly with the critically ill and ventilated patients with the hope to ventilate patients in the unfortunate event of running out of ventilators. And this also should be sent out to at least for providers to have knowledge in case we meet the dire circumstance of not able to save patients because of need of ventilators. I would like to add quickly here that there are many rumors going around the internet about connecting multiple patients with a single ventilator directly, and media is also highlighting that. Please do understand that it does not work that way, and please be understanding to your healthcare provider when they tell you that they cannot connect multiple patients on a ventilator. We have known this for years, at least since 2006, and there is a reason we have not done that. The best analogy I can give you directly about connecting multiple patients to a ventilator is of connecting different balloons and footballs to open faucets in your house, and then opening the master valve, hoping that each balloon or football would get the same amount of volume of water or same amount of pressure, which we know is not possible. We would definitely damage healthy lungs, which are like balloon, or not get enough pressure into unhealthy lungs, which are like football. Not saying that even different balloons would have different elasticity or compliance at a given time. Therefore, it is very dangerous to do that and would even harm people who have chances of survival if we connect multiple patients that way. I can only think of one scenario it can happen is when we are trying to do elective surgery or we are ventilating healthy lungs. Maybe at that time we can ventilate patients for a few minutes to a few hours with very close observation if we are lucky. There is no way this can be used to ventilate unhealthy lungs, as their compliance, their elasticity, and their parameters vary between different patients. And even if we try to select similar patients, it's not possible because with time their needs can vary and dire things can happen. Ventilating lungs is a very complex process, and there are many variables involved, such as compliance, inspiratory and expiratory time, pressure ramp, etc. Again, the described modification of the ventilator is intended to be a salvage therapy and can only be used in the situation where a choice has to be made between letting the patient die because of lack of ventilator versus giving them a chance. This cannot in any way substitute for single ventilator ventilation because of the reasons above, and any person familiar with mechanical ventilation would know. Please feel free to distribute this video to any place or person running low on ventilators so that they at least have an option to think about it in dire circumstances. This video would become technical further on again, as this is intended for respiratory therapists or intensivists familiar with mechanical ventilation. By modifying the ventilator with supplies readily available in the hospital, with the exception of ball valve, which is readily available in any hardware or plumbing store, most of the ventilators can be modified to ventilate multiple patients with individualized pressure or volume and even PEEP. Please refer to my previous video for a detailed instructions on how to set up the spirometer and other connections for measurement of volume, etc. The blue lines denote the
inspiratory limb, and the white lines denote expiratory limb usually.
Here I have demonstrated the artificial lungs being ventilated with different pressure and volume and even different beep. And changes in one does not actually influence any change in parameter of the other lung. This can be extrapolated to 4 or 5 patients in terms of need. Just to summarize again, the blue expiratory tubing is connected to the modified incentive spirometer, which I have explained how to make in the previous video, and it is connected to the white tubing, which in turn is connected with the suction catheter tubing and to the lung. The cuff pressure meter, which is readily available with respiratory therapists to measure the cuff pressure, is connected by hooking it directly in the suction tubing and measures PEEP and peak pressures in real time. There is a valve in the inspiratory limb which is used to modify the volume or pressure, whichever is needed in each individual patient according to need. If you look at the other lung, the inspiratory limb is again connected to ball valve, which is connected to suction tubing and to the ventilator. The suction tubing is again connected to the pressure gauge meter. This is the simplest setup for the second lung, which can give individual pressure control ventilation without affecting the other patient in real time. Please do note that the smaller the ball valve is, the better sensitivity is, and you'll have good uh, um, way to regulate pressure or volume and would be preferred. Here I have used 1/4 of an inch ball valve which hooks up directly into the 1/2 inch adapters and does not need any modification. For demonstration I have also shown a bigger ball valve which serves the same purpose, however is less sensitive, and even a minor variation can cause changes in pressure volume. Therefore I prefer the smaller valve for safety reasons. The ventilator pressure can be set at around 30 to 35 as long as none of the patient needs higher pressure, again for safety reasons. However, even if the pressure is increased to 50 or 60 centimeters of water or even higher, the pressure transmitted as measured by the pressure gauge is still less than 30 or even 20 given significant resistance used with the use of ball valve. And for this reason, the ball valves have to be in minimal open position during the initial setup. This setup is a slight modification from the earlier setup which I had used in order to show how even PEEP can be managed differently in different patients. This I have achieved by use of peak valve, which is usually found in conjunction with embo bag. Currently, if different PEEP is desired with use of a simple hose, it can be converted into a closed circuit. If different PEEP is not needed, then it would be a closed circuit anyways. Again, please refer to my earlier video for initial circuit diagram, as this is a modification and slightly more complex circuit because of requirement of different PEEP, especially if we are ventilating very sick or patients with poor lung compliance such as ARDS. Now here, if you see, I have adjusted the PEEP to be 8, which is inherent PEEP of the ventilator, and I have changed PEEP on the first lung to 12, and this is the circuit with peak flow meter attached. Again, I have not made this a closed circuit because of time constraints, and as different PEEP may not be needed all the time, and because of time constraints, now I am changing the PEEP with a peak flow meter. If you see, and lowering it again, and if you see, the PEEP is lowered to 8, It is important to have a closed circuit and good to have one-way valves for spirometer to work. These are the pressure settings I have used with trigger of negative 11 centimeter of water so that patients do not trigger the ventilator, and they should be, needless to say, adequately sedated. Of course, I would prefer them to be paralyzed. I would also prefer the inspiratory time slightly higher than normal in order for the tubing to have adequate pressure as we are ventilating multiple patients, though it does work with normal inspiratory time too. Here is a picture of the ball valve and the connection in the inspiratory limb. Here is another ball valve which is less sensitive as it is big but does work. I would again recommend to use the smaller ones as there is less chance of accidentally opening it fully, resulting in sudden changes in volume or pressure. If we keep the pressure and inspiratory time higher on the ventilator, there is almost no change to other lung while changing settings on another lung. This prototype is working and I have been able to change settings on individual lungs without affecting any setting on the other lung. However, I would strongly recommend, and it would be good to eyeball pressures and ventilation on other patients once we change settings on one patient. Again, I hope that we get enough ventilators in timely manner available not to be in this situation, but we may use this to save lives when we do not have any option and should not let people die because of lack of ventilators. Needless to say, I think the patient needs to be in the same room and there has to be constant monitoring by either a family member or preferably by a nurse or respiratory therapist of different pressures, as we would be without ventilator alarms for individual patients in this case, and most likely the alarms would be silent given we are using higher pressures. If a patient deteriorates or is not able to ventilate, the valve can be switched off and the patient can be ventilated with bag and mask without affecting any other patient till the situation is resolved. Also, we can connect a suction tubing in parallel to suction the patients while measuring pressure with another suction tubing at the same time. Please do keep in mind that the incentive spirometer has to be encased in a airtight container which needs to be rigid as there is and would be sufficient pressure inside the container, and preferably needs to be sealed shut with industrial grade adhesive and reinforced with tapes or screws, etc. At this time, I would also reach out to our engineering friends and see if we can modify the ventilators which have pressure flow sensors and combine them in one so that even if one patient's peak pressure goes high, the ventilator gives an alarm. That would be an ideal situation. I think this can be done by combining wires of multiple sensors into one and modifying either the output or the sensory alarm in the ventilator to go with the highest pressure. For our engineering colleagues, I don't think it should be that difficult to incorporate pressure flow sensor and a valve which can measure peak and peep directly along with pressure and volume and set alarms based on specific parameters for individual patients. That would be a very small device and can work. This would actually solve the problem in the future if we again run into this unfortunate situation again ever. Again, I'm a pulmonary and critical care physician and these views are completely my own and are not affiliated to any institution in any way, and they should not be held responsible for the content of this video. I would also like to reiterate that at this time I do not endorse this method of ventilation in any other way because of the reasons above, except when a patient will not make it because of need of ventilator. constant supervision is very important and needed 24/7 because the ventilator would not be able to sound alarms in this case. Please feel free to add suggestions or comments, or if you have any questions, please do forward this to any healthcare provider you know or is in a situation where they are running out of ventilators. Thank you very much.